Hello and welcome back to the Central Nervous System Pharmacology Masterclass. Here we will talk about the buprenorphine. Buprenorphine is another opioid analgesic medication, and here we will talk about the definition, the pharmacokinetics, the mechanism of action, the therapeutic uses, and the adverse effects of this medication. You can always use the chapters in the video description to skip to other parts of this video. And regarding the pictures, on the left we have the chemical structure of the buprenorphine. The black spheres are for the carbon atoms, the white spheres are for the hydrogen atoms, the red spheres are for the oxygen atoms, and the blue sphere is for the nitrogen atom. The right picture here shows the transdermal patch of the buprenorphine. So let's start with an overview of the buprenorphine. So it is a synthetic opioid. It works as a mixed agonist-antagonist, which are also called a partial agonist. So it works as an agonist on some opioid receptors, and it works as antagonist on the other opioid receptors. And more explanation on this point in the mechanism of action part of this video. It was synthesized in late 1960s, and it is a derivative of the thebaine. The thebaine is a natural opioid that is isolated directly from the opium plant. And it is famous for its use in treatment of pain, and it's also used in treatment of opioid misuse disorder. Now let's talk about where the buprenorphine sits in relation with other opioids. So regarding opioids, we have the natural, we have the semi-synthetic, and we have the synthetic opioids. Both of the natural and the semi-synthetic opioids work as agonists on the opioid receptors. And examples for them are the morphine and codeine for the natural, and the heroin and the hydromorphone for the semi-synthetic. And then we have the synthetic opioids, which are on three types: the agonists, the antagonists, and the mixed agonist-antagonist. And the buprenorphine is included in this group, the mixed agonist-antagonist synthetic opioids. The other members of this group are the nalorphine, the nalbuphine, the pentazocine, the butorphanol, and of course the buprenorphine. Now let's talk about the pharmacokinetics of the buprenorphine. So it is available in sublingual, buccal, transdermal, intravenous, and intramuscular formulas. You notice that there is no oral formula with the buprenorphine because there is an extensive first-pass metabolism that occurs if it used orally. The bioavailability of the sublingual is 30% and of the buccal is 65%. And is metabolized by the liver by the CYP3A4 and CYP2C8 enzymes. The onset of action of the buprenorphine is after 30 minutes of administration, and elimination half-life is around 37 hours, and duration of action is about 20 hours, which are all of those are long numbers. It has a long duration of action and has a long elimination half-life compared with other opioids. It is executed through the kidney and liver, through urine and bile. Now let's talk about the mechanism of action of the buprenorphine. So we mentioned that the buprenorphine is a mixed agonist-antagonist, meaning it works as agonist on some receptors and antagonist on the other receptors. So it acts as a potent partial agonist at the mu receptors. And to explain what a partial agonist is, we have to draw the dose-response curve. So this is the dose, and here we have the response. And so the partial agonist would give us a certain effect with increasing the dose. So if we give a lesser dose, it would start like that and then increase until it reaches that. And even when we increase the dose, it is still at this amount of effect. And that is the partial agonist. The full agonist, on the other hand, it would produce more effect when it binds to the receptor. So it starts like that and it would produce more effect compared to the partial agonist. So the buprenorphine is potent, so it binds potently to the mu receptor, and it works as a partial agonist, so it produces less effect than with the full agonist like the morphine and the heroin. And it also works as antagonist on the kappa and delta receptors. So it is agonist on the mu and it is antagonist on the kappa and delta. And compared to morphine, for equivalent dose, the buprenorphine sublingual is around 50 times more potent than morphine and 100 times more potent if used as a transdermal patch. Buprenorphine can displace full mu agonist like the morphine because it is more potent. It is 50 times more potent if it used sublingually and 100 times if it used in transdermal patch, leading to withdrawal symptoms in opioid physically dependent patients. So because it produces less effect, because it is partial agonist, so when it binds to the receptor instead of the morphine, it would give lesser effect. And this would lead to withdrawal symptoms. So the patient is physically dependent to a certain effect. And when you displace the morphine and you give them lesser effect, they would get the withdrawal symptoms. Now let's talk about the pharmacologic effects of the buprenorphine. So it provides analgesia that is good for moderate to severe pain, but it can antagonize the analgesic effects of agonist opioids like the morphine. So if it is used when they are being used on a patient, because it produces less effect, because remember it's a partial agonist when it binds to the opioid receptors compared to the full agonist opioids. Buprenorphine provides less euphoric effects, thus it provides less abuse potential than the agonist opioids. So the euphoria that comes with the buprenorphine is less compared to the full agonist opioids like the morphine and the heroin, so it has less abuse potential. The risk of respiratory depression is lower when compared to agonist opioids for the same reason, because it produces less effect when it binds to the opioid receptors and it slowly dissociates from the receptors it is occupying, so that is why it has a longer duration of action and mild withdrawal symptoms once withdrawn. So when it unbinds from the receptors, it slowly unbind, and that is why it has longer duration of action. Now let's talk about the therapeutic uses of the buprenorphine. So it is used in treatment of chronic pain as a transdermal patch. It has a long duration of action, which is around 24 hours. And it is also used in treatment of opioid addiction or opioid dependence. That is the same with the methadone. Remember, the methadone was also used in treatment of opioid dependence because of its long duration of action, providing less withdrawal symptoms when withdrawn and blocking the effects of any agonist opioid if they are used during the buprenorphine effect period. So if the patient decides to go back to their medication of abuse, the medication of abuse would produce no effect because the buprenorphine is potent and it is binding to the opioid receptors, so it would not get displaced easily, and that is why there is no effect for those drugs when taken. It is proven that it has shorter and less severe withdrawal symptoms compared to methadone. So it is better in that regard. It has less severe withdrawal symptoms. Buprenorphine, when used in treatment of opioid misuse, it is used in combination with naloxone and used sublingual or buccal. So when this combination, the buprenorphine and the naloxone, when used sublingual or buccal, the buprenorphine is absorbed and the naloxone is not absorbed. And if the combination used intravenously, Like some patient would try to make the combination into intravenous formula to get high with it. So the naloxone would be absorbed and it would bind into the opioid receptors, leading to acute withdrawal. So it can't be used intravenously, thus the patient can't abuse it. This is the famous trade name for the buprenorphine and naloxone. It's called Suboxone. Now let's talk about the adverse effects of the buprenorphine. So one of the adverse effects is the respiratory depression, but buprenorphine doesn't cause the respiratory depression unless it is very high dose. But once it causes the respiratory depression, it can't be reversed by naloxone because the buprenorphine is very potently bound to the receptors, to the opioid receptors, so it can't be displaced easily by naloxone. That is why it can't be reversed, and the patient need respiratory support in form of putting them on ventilator until they recover. And the risk of respiratory depression is higher if buprenorphine is injected intravenously with benzodiazepines. So if the buprenorphine is used intravenously with benzos, the risk of respiratory depression gets higher. And also lead to increased blood pressure because it increases the systemic and pulmonary vascular resistance. It also has effects on the heart. It leads to prolongation of the QT interval there, and it is risky in cardiovascular disease because it may lead to torsades de pointes arrhythmia. It also leads to psychotic effects like hallucinations, nightmares, and anxiety. It also leads to opioid dependence or opioid addiction once used recurrently, but it has less addiction compared to agonist opioids because the mu receptors make the most euphoria. And remember, the opioid dependence is related to euphoria, and the mu make the most euphoria. And since buprenorphine doesn't activate mu that much compared to agonist opioids, so it produces less euphoria since it leads to less addiction. It also leads to nausea and vomiting because of the activation of the chemoreceptor trigger zone in the brainstem. It leads to constipation because of its effects on the intestine, and it leads to headache, mild amnesia, which is mild forgetfulness. It leads to cognitive and neural inhibition because of the inhibitory effect of this drug on the central nervous system. It also leads to pruritus due to histamine release because with the buprenorphine there is histamine release which makes the patient itch. And there is risk of seizures if it is used in epilepsy patients, and it leads to meiosis, which is constriction of the pupils, and it leads to urinary retention because it increases the bladder tone and it increases the urethral sphincter tone, which traps the urine, and it may lead to urine retention at the end. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like this video and subscribe to the channel. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this video. Thank you for watching, and peace.